Good morning. It's nice to see so many familiar faces here. And I'm going to speak slowly because my speaking coach is somewhere in the audience. And she criticized my speech from last night. So I'm taking a breath. I'm taking a pause. Okay? All right. So everyone asks me in the clinic, how common is this melanoma? And of course, it's not a common disease. But still, when you see many people here, you feel that you're not alone. So in any case, the incidence, the best estimate we have is about 4.3 per million. So that's, you can multiply by whatever number, and you see that's not, you see thousands and thousands of cases, but we see a fair number, and that also makes it a little difficult to get funding and support and grants, etc., because this is considered an orphan disease. We don't have many people affected by it, and we are not a priority. Just to tell you that this SEER data that I published, when I went to NCI asking for their help to calculate this data, to get the numbers, they wouldn't help me because they said this wasn't important because they had breast cancer, prostate cancer, lung cancer, all lined up. So I found someone else, and we managed to do it on our own. So this tells you the reality of the problem. But so it's not very common. And the people also ask me in the clinic, what happens in the rest of the world? Well, it's pretty much same as what happens in the United States. It's basically white populations across the world have similar incidence. And the number 0.3 is in Japan. It's a different race. So people like myself, African Americans, Chinese, would be less commonly affected by melanoma. I actually have only 3 African Americans in my clinic over the last 11 years. So it's uncommon. There's a lot of racial variation with this. And unlike skin melanoma, the incidence of uveal melanoma has not increased at all. It has remained the same for the last 25 years. And in fact, if you look at the data even before 1973, it's just about the same. So it's not getting more common. It's just that we are getting more aware of it from social media and other things, or maybe a foundation like Ocular Melanoma Foundation. And the other question I'm asked all the time is that, shall I start wearing sunglasses now that I have uveal melanoma in one eye? And I can tell you that the best evidence so far, looking at different aspects, indicates that sunlight most likely is not a factor in causation of uveal melanoma. So skin melanoma, the incidence is rising, attributable to sunlight exposure and perhaps early detection. But for uveal melanoma, there is none. So you can go ahead and go to this topless beach in Punta Cana, huh? Okay. You did not notice that, huh? Okay. Anyhow, so if you came to Cleveland Clinic, or hopefully not, or someone in your family or someone else just walked in, what do we normally do and how would you go about it? So in the next 5 minutes, I'm just going to share that very quickly. So we do an eye exam, of course, we do a test of the eye, etc. And after making the clinical diagnosis, I classify it by size. How big is it? Because everyone says I have a large tumor, a small tumor. But we follow a certain criteria to classify this. And then we talk about the eye treatment and we talk about the rest of the body. So both are equally important. And we'll get into the systemic staging. That is, at the time of initial diagnosis, we typically do CAT scan or chest, abdomen, pelvis, and blood work for liver. And later on, we typically would do ultrasound of the liver every 6 months for the first 5 years, and once a year after that for another 10 years, unless somebody is very old or doesn't want it, or there are other reasons that may be affecting their lifespan. So those are the mitigating factors in all of this. I don't say that or claim that this is the best way forward, but this seems to work for us, and I have some reasons for it, and we can discuss that further as when we have the panel discussions. So part of my reason of my presentation is also to set the stage for the discussion, science panel first discussion and the second discussion. So I use the standard classification of collaborative ocular melanoma to call it small, medium, and large. So we all are referring to the same size, we are all referring to the same thing when we communicate with you or communicate with the other doctors or other colleagues. So I do want to have a reference, and this is the reference I use, and I classify every patient according to the size. Right or wrong, this is what we use, a template. And typically for a small tumor, many of them may be just moles, we just observe, and for the ones that we think are melanomas, we would treat them with radiation, typically plaque radiation, and perhaps proton in some other parts of the United States. And if it's a medium-sized tumor, our treatment of choice is radiation plaque therapy, brachytherapy. This has been around for more than 60 years and has almost 95 to 98% control rate. So treatment of choice, we talk about medium tumor, unless there is no vision in that eye or there's no potential for vision. And I listed some other treatments that may be equally effective. And when we talk about brachytherapy, which is what we use most commonly, or this is what's used most commonly in the United States, 85% of patients with uveal melanoma are estimated to undergo brachytherapy in the United States. So there is options of radiation implants. We have more commonly used iodine, but ruthenium is also available. It's typically used for smaller tumors and may have a better or more safe dosage profile. Just in simple terms, the dose to optic nerve and macula may be less, and therefore the vision outcomes might be better. If you looked at the tumor control rate in both types of implants, there are similar graphs indicating that the control rates are equally effective. And in our center, almost 95 to 98%. So here's a gentleman, I don't see him here, but was treated almost 10 years ago with a medium-sized tumor. You can see near the optic nerve. You all are probably familiar with this part of anatomy. Here's the tumor. This is the ultrasound with this little bit of detachment. And we can see 10 years later, the tumor is regressed, never disappears completely, but the optic disc is still normal and the tumor is smaller. And if you look at his vision is 20/20. So that's a great outcome. Doesn't happen in every case, but this is not surprising. This is because if you actually were to calculate the dose to the optic disc and macula, you find that with using one implant versus the other, you can reduce the dose of radiation to what's critically important for vision. So this is planned. You're choosing one versus the other, figuring out ahead of time which kind of implant would give best vision, and this is an example of that. And then when we come to large tumors, the treatment of choice really is enucleation. But of course, we have alternatives based upon if the patient has only one good eye or is not keen to have enucleation, then there are other available methods. So just to summarize, for small tumors, we do either observation or plaque radiation therapy. For medium type, the treatment of choice is plaque radiotherapy or brachytherapy, and large is just the other way around. So this is pretty much how we do in our clinic. And if you look at the national data, this is not data just from our center, but within the United States, there's an ongoing program of NCI that samples 26% of United States population for all cancers and outcomes. So all the data you hear about breast cancer, lung cancer, prostate cancer comes from the same database, and we can extract the data for uveal melanoma from the same database. And that's telling us that the brachytherapy is getting more and more popular over time, and that's not surprising because it's effective. And the rates of enucleation are pretty much going down, again, because of awareness of radiation. But if you looked at the outcome of patient survival overall, you can see the line is straight. So that's telling us that despite all the methods of treating the eye and saving vision, etc., but the risk of metastasis, of course, has not changed. So from 1970, and this is even adjusting for improved lifespan in the United States, from 1973 to 2008, the lifespan has increased, but even if you adjust for that, there is no improvement in survival. And that's because we know from all the data that the tumor tends to metastasize at microscopic level to the liver, and it's when you do a baseline testing for the eye examination or the time of eye diagnosis, the liver involvement may not be detectable. And we can nowadays, using biopsy techniques which are safe, sample the tumor and be able to predict which patient is likely to develop metastasis, and the different tests that are available. Some are commercial, some are experimental, some are institutional, but different tests are available, and we can determine or predict who might get into metastasis. And of course, this process of metastasis is not a passive phenomenon. There is the body is reacting to the tumor, and you can, in the blood, test for cells, immune proteins, immune reaction to the cancer that's present in the eye. After all, it's also a foreign thing. It's like a bacteria. It's not innate to the body. It's something different. And Dr. Triozzi, who is right at the back, with him, we have studied some of these aspects of the body's reaction. So it's possible that in the future we may have blood tests that may give you similar information as the biopsy gives us now. So we may not have to do a biopsy, but just by a blood test be able to do. So that's one important area of research. And of course, the more important area of research that you'll hear from the other speakers is the role of adjuvant therapy. So when the patient we suspect has micrometastasis, you find ways to get rid of those cells that may become larger with time. And unless we focus on these areas of research, the curve, I'm afraid, is not going to change for another many years. So with that, I conclude my presentation. This, I think, sets up a good stage for prognostication testing, immune surveillance or other surveillance techniques, adjuvant therapy, and maybe perspectives from other sides of the pond, from Dr. Bertul D'Amato, and Dr. Sabula is also going to talk about the other possibilities of adjuvant therapy. So thank you very much for coming and asking me to contribute. Thank you.